respected members of Maharashtra State Chapter ISA who have logged in for this webinar on the Zoom platform as well as to the YouTube channel. We are very delighted to have today with us Dr. Meenakshi Sundaram and as well as Dr. Pratibha Khani Madam as speakers, and Dr. Anjali Savargaonkar Madam and Dr. Surekha Shinde Madam as chairpersons and moderators for this session. Whenever we are practicing anesthesia in day-to-day life, we are always worried at the back of our mind about medical legal issues. Even the discussion for academic cases or the discussion for the academic events end that if there is a medical legal issue in such case, what we will have to face. So we are always, although the medical legal cases are not very rare, but still the medical legal claims are little bit uncommon, and we are always worried about those medical legal claims because we have to that there is going to be a burden of lot of financial aspects also if you have to face the medical legal claim. So we have eminent speakers today. The madam is going to tell us about why the anesthesiologist is sued for any medical legal issue or any medical legal problem, and sir is going to tell us about how to avoid these medical legal issues or what will be the implications of medical legal issues in day-to-day practice of anesthesia. I welcome you, madam and sir, and a warm welcome on this platform of Maharashtra State Chapter ISA. I would request Dr. Anita Mehte madam to welcome Dr. Meenakshi Sundaram sir and introduce him. He doesn't need actually any introduction.
Yes, thank you, Manisha madam. I am very privileged to introduce Dr. Meenakshi Sundaram, and actually really sir doesn't need any introduction. He has spoken to almost all parts of India, and his very humorous style of presentation is very popular. Dr. Meenakshi Sundaram is a Dean, Government Medical College, Perambalur, Tamil Nadu, and he has been the Vice President of ISA National in 2016, and lots of positions he has held at ISA National. Important positions like he was a GC member of ISA National, and he was a former President and Secretary also of ISA Tamil Nadu. Sir has been ISA National faculty for past 22 years, and he's an accredited speaker by MMC. He has got Best Teacher Award by Tamil Nadu Dr. MGR Medical University, and also a Best Doctor Award by Government of Tamil Nadu. He is also a Tamil scholar and awarded by Government of Tamil Nadu. He is a popular Tamil poet, and he has published many poetry books. So we welcome you, a multifaceted personality, Dr. Meenakshi Sundaram. Welcome, sir.
All-round personality.
Yes.
Thank you so much, Anita. Good evening to all. It's my pleasure to introduce our friend Dr. Pratibha Khani. I'll go into the bit reverse way. She is MD anesthesia with gold medal from Pune University, from BJ Medical College. And in addition to that, subsequently, she has done her LLB with honors. So since then, she is one of the stalwart in the medical legal aspects of this thing with not only with our fraternity, but all the branches, wherever the national and state conferences are there, she is there as an faculty for the medical legal issues. Of course, she is a postgraduate teacher since so many years. Since 97, I know she started this course in front of me only in Jangir Hospital. In addition to that, she has been ordered the certificate from the Oxford, UK, as a healthcare communication. And as I said, she has got a gold medal in anesthesia for the MD, and she had got on her credit most of the places in the state level conference. She is always there for the medical legal. In addition to that, as per my knowledge goes, last 30 years, she was well-known pediatric anesthetist beginning. Subsequently, she is a all-rounder because I used to see her since last 30 years in Jangir Hospital as an all-rounder anesthetist. What else? There is a lot to talk about her. She was the past president of Pune, I say, and she is rather, and she kept that moment of time very vibrant. This Pune city ISA branch, and I think probably every month everyone was rocking that moment of time. So those are the sweet memories. Thank you so much.
Thank you, Sai sir. It's my pleasure to introduce our today's chairperson, Dr. Anjali Savargaonkar Madam. Madam is MD Anesthesia and ex-professor and HOD Government Medical College, Nagpur. Madam had taken just voluntary retirement from government service just few days back. Madam worked at Government Medical College, Nagpur and GMC and JJ Hospital, Mumbai. She is examiner for MD, DNB and DA anesthesia at various medical colleges, AIMS and DIM universities in different states. She authored a chapter in book Comprehensive Clinical Anesthesia. Madam was invited as faculty and done paper presentation at various national and state conferences. She was awarded as a most active member of ISN Nagpur City branch in 2008. Welcome, Madam.
It's my pleasure to welcome our second chairperson, Dr. Surekha Shinde. She has done her MBBS and MD anesthesia from BJMC Pune. She has done many other qualifications in her armamentarium, like in emergency medicine, medical education technology, PG diploma in medical legal systems. He has also done certificate course in palliative care. She has more than 20 indexed journals publications. Received COPS Award for Best Paper in Neuroanesthesia in Nagpur Conference. Award for poster presentation at Mysore National Conference. She has delivered many presentations across state and national conferences. She is a examiner for MBA, DNB anesthesia. She was in charge of COVID ICU and as expert in Pune Oxygen Committee. She has authored a book chapter on COVID management also. She is also a member of ISA National Task Force for COVID-19 Management, and she has been awarded President's Appreciation Award for her COVID work in ISA Maharashtra MSCISA, also by ISA National. Welcome, Dr. Surekha Shinde.
Now I request Dr. Meenakshi Sundaram sir to start his.
No, sir. Avinash, just a wait. Avinash, just a minute. There is some change in the program because the topic was something different. The topic for madam is why do patients see the anesthesia provider? And the topic of Meenakshi Sundaram sir is how to avoid or what will be the medical legal implications of after the claim or after the medical legal case. So we would request Khani madam to start her lecture.
Okay, no problem. Madam, please.
Okay, I'm sharing my screen. Just check that, please.
Yes, madam.
Yes, madam. It's visible. Just.
Okay. Now again, this has gone back to. 1 second. I just need to change that. I'm getting that. 1 second.
Slides clearly. We can see the slides.
No, I want to. No. I just want to take this because all your faces are coming again in my.
Madam, they will come. Like get them out of the screen. Get us out of the screen. Move us out of the screen.
All right. Okay.
Yes.
All right. Is that okay?
Yeah, ma'am.
Yes, madam.
All right. So I really thank Maharashtra State ISA and Manisha Katikar for giving me this opportunity to present my topic. And I'm actually very honored to share this space with Dr. Meenakshi Sundaram. So with the permission of our chairpersons, I will start. And my topic today is, why do patients sue their anesthesia provider? And the simple answer is because they think we have been negligent. In legal terms, we have a legal duty towards all patients that we agree to give anesthesia. There is a breach of this duty, which leads to some injury or complications for which the patient or their relatives want compensation. For monetary compensation, they approach the consumer court. If they want to see us behind bars, they will approach a police station to file an FIR and start criminal proceeding. And they may even approach the State Medical Council to revoke or suspend our license to practice. Till 1998, anesthesiologists as an independent specialty was new in law. So it gave us a kind of a parda or a legal immunity. That is because of that traditional principle that the surgeon was the captain of the ship and the anesthesiologist worked under his direction. And so the liability was only of the surgeons. The anesthesiologist was thought to be a servant of the hospital or the surgeon, as the patient did not directly hire our services. So there was no privity of contract between us and the patient. Then came 1998 and this landmark judgment of Mumbai Grahak Panchayat versus Dr. Rashmi Fadnavis. The facts of this case are that there was a 130-kilo patient who was given spinal anesthesia in a private clinic for a hysterectomy. She developed intraop complications. GA was supplemented, and after 7 hours, the patient had a cardiac arrest and died. The Maharashtra State Forum held only the gynecologists liable for negligence, for not having infrastructure to manage a high-risk patient, no ventilator, no defibrillator, no generator backup, no long needles for intracardiac injection, and the A-negative blood was also not ready. The husband appealed to the National Commission to include the anesthetists and to increase the compensation. The award was not increased. It was 2.55 lakhs plus 5,000 as cost. The anesthetist was yet not held negligent, but the liability of the anesthetist was clearly defined in this judgment. So the anesthesiologist now is an independent professional hired for service. He uses his own skill and judgment to take care of his patients. He is not under the direct orders of the surgeon or the hospital, so there is no master-servant relationship. The patient is our customer as he pays for our services. So the anesthesiologist is separately liable for negligence under the Consumer Protection Act of 1986, now 2019. So litigation against doctors has increased by 400%. And the objective of this masterclass is to analyze some of these judgments and understand the issues which are being litigated, as the law of medical negligence is not codified. And this might help us to prevent litigation by addressing these issues in our current practice, or if at all there is a litigation, we can offer a strong defense. So let us start with issues in our practice. The first is, do you have the necessary qualifications and are you registered in the state that you practice? In this case, from Maharashtra, Pune, a 5-year-old child with bilateral renal stones was operated under general anesthesia. The patient suffered hypotension and bradycardia and died the same day. It was found that the doctor giving anesthesia did not hold any degree in anesthesia. Mind you, he had been practicing for the last 25 years. the hospital has been held negligent for employing a non-qualified anesthesiologist. Now, this is just a red flag that do not practice beyond your qualification. And soon, for super specialty, we might be required to have additional qualifications. Registration, anybody who is even touching the ultrasound machine must be registered with the local PCP and DT authorities. And there is some, move in the new NMC to come down heavily on anesthesiologists who or any other personnel who is acquainted or working with Ayush personnel. So the next thing is pre-anesthesia evaluation. So not performing a pre-anesthesia evaluation by itself is a deficiency of service and negligence. In this first case, spinal anesthesia given for a fractured tibia, the history of head injury was missed, and the anesthetist has been held negligent under the CPA and also booked under 304A. In the second case, on induction of anesthesia, the patient develops bronchospasm. Now, the anesthesiologist claims that the patient had asthma and was trying to claim it as a defense, but this was not mentioned in the pre-anesthesia notes. So it was yet held as negligence. This is, I think, a landmark case for us because this is Aruna Ben Kutari versus Navdeep Clinics. In this case, hypertension was noted by the cardiologist and the anesthesiologist at the pre-anesthesia consultation, but ECG or further tests was not advised. The patient was taken up for elective non-emergency fixation of the radial deformity. Patient has a cardiac arrest, intra-op, and dies. It was held as negligence, and a compensation of 4,15,000 was given. But what I would like to draw attention to is the apportionment of liability. It was 60% to the anesthetist, 30% to the orthopedic surgeon, and even the cardiologist has a 10% liability. Improper consent and improper documentation are the two giant killers of doctors in court cases. According to the Institution of Law and Medicine, at least 60 to 66% cases go against doctors because of these deficiencies. So let us look at consent. Over litigation for negligence, the consent is scrutinized in two specific ways. Is there a consent? And is the consent valid, appropriate, and proper? Not having a proper consent is deficiency of service. So the process should be plan of anesthesia and counseling before consent. Let us look at some case law. Now, in this first case from Gangaram Hospital, Delhi, consent was taken for abdominal hysterectomy under GA. Spinal epidural was given and vaginal hysterectomy done, a totally different route for which no consent was taken. Complications developed and needing further intervention, and this was held as an invalid consent. Of course, Samira Kohli versus Dr. Prabha Manchanda is the landmark case where they say that do not extend the procedure beyond the consent in non-emergency situations, even if it is for the benefit of the patient. So here I would like to bring to your notice that when you are giving a caudal epidural or a peripheral nerve block for the benefit of the patient in the post-operative period, it has to be mentioned in your anesthesia consent because each one has a small risk of its own. There are other reasons why consent has been held invalid. Here, the patient is competent, but the relatives have signed on the consent form. So many times the father-in-law, mother-in-law a husband signed, but a competent patient does not sign, and that is held as negligence. In the first case, there was a boy, 20 years old, mother had signed. In the second case, 80-year-old patient going for a colonoscopy, and the daughter had signed, in spite of the fact that the 81-year-old was absolutely competent. In this next case, the consent was not taken for blood transfusion, and the patient developed HIV infection, and that was held as deficiency. Of course, not taking a patient's specific consent for telecasting any images or information of the patient is definite negligence. The most important, or why consent is getting rejected as invalid, is what they call now as negative counseling, and which means that the risks were not explained. I think everybody must be knowing Dr. Mahadev's case in 2018. The patient himself was a doctor, but he claimed that the risks of ERCP surgery were not explained to him. And look at the damages awarded, almost 13 lakhs. In an emergency, of course, no consent is required. And in fact, if you delay surgery for consent, that itself may be held as negligence. Let us look at some intraoperative deficiency which cause litigation. The first is wrong side surgery. This is held as res ipsa loquitur. And in this case of Fortis Hospital in 2016, the patient, the 24-year-old, a wrong ankle was operated. And the anesthetist tried to take the position or the defense that I was busy with the patient, so I did not pay attention to which leg was getting operated. But this has not been accepted, and already he has lost his job. And the Delhi Medical Council has taken suo motu action on all the doctors involved. And there is also a criminal case which follows. Allegations of anesthesia overdose are very common in children who suffer complications mostly for tonsillectomy or setting of green stick fracture. Most of them have incorrect dosages written in their documentation, and nobody should undertake pediatric anesthesia without experience. On the other side is awareness, and this is the famous UK case, Ackers versus Wigan Healthcare Authority. Here, a patient was given general anesthesia for LSCS. The patient was conscious throughout her surgery, that she suffered a severe post-traumatic disorder. She could not even do her day-to-day activities properly, and an extremely large payout was done. Another case from UK, this is the anesthesia error, especially intrathecal and epidural. We have to be extremely careful of the drugs that we are giving. Here, the wrong drug, that is the chlorhexidine, was given instead of local from those bowls where the local was taken. And the patient has had severe paralysis. And the patient had to undergo many surgeries, and the patient lives as of now. And this was held as negligence. And see what the judgment says, that haste and flurry is not acceptable in an area needing the highest standards. And this case was awarded one of the highest compensations of that time. Smartphones or mobile phones are definitely going to be our bane, because the distraction is clearly documented. Here, a 61-year-old patient was undergoing a routine pacemaker placement. Hypotension was missed for almost 20 minutes, and the patient died in 10 hours. The anesthesiologist was sued for texting and reading iPad. He actually admits that he put 2 Facebook posts with the patient picture and the internet. He was browsing on the internet for those 20 minutes. And definitely this case cannot go to trial. So it was settled for a very, very large sum before going to trial. We are responsible for safeguarding the patient's privacy and dignity. And in this anesthesiologist from Dallas was liable for sexually abusing 7 patients under his care and sentenced to 23 years in prison and 14 million in damages for pain and suffering. This is just a red flag for a fully male team operating on a female patient. Working without a defibrillator in many multiple of cases has been actually called recklessness, carelessness, and callousness and overconfidence by the anesthesiologist and held as negligence. Not having an access to blood bank or not being able to give blood transfusion for PPH is also an issue for litigation. Now, this is the case from January 22, rather worrying because the Karnataka court has convinced 3 doctors for the death of a woman for operating without a ventilator facility and life-saving equipment. This is a criminal case booked under 304 and section 34. 34 section is criminal intent, or, that everybody gets together and wants to bring harm to the patient, and the doctors to undergo simple imprisonment of 2 years and a fine of 10,000 each. Very worrying. And as if this is not enough, this is from Thane. This is April 22. It's this news says 2 surgeons, 1 anesthetist, and nurse booked for allegedly leaving a surgical mop in the abdomen. The patient herself is a doctor. She had undergone an LSCS, and for 2 months she was complaining of pain in abdomen, and she had to undergo another surgery where a 10 by 10 mop was removed. But look at the new trend of involving everybody. So the anesthesiologist, which we think is really not concerned with mops, we are also going to be made responsible. Again, section 34, which is a criminal conspiracy. Post-operative vegetative state will definitely get litigated in today's era. In this first case, LSAS under spinal anesthesia patient did not regain her consciousness and remained in a vegetable state. Here, the doctors were not held negligent. This is a Mumbai case. But the second case here, the patient's operated for a slip disc, goes into a vegetative state. The anesthetist license is suspended for a year by the Karnataka Medical Council. This is 2013. Post-operative spinal hematoma, I would really like everybody to be acutely aware of this complication. This was a simple spinal for an LSCS. The patient complained of back pain and paraplegia, which has gone unattended by a doctor for almost 14 hours. The patient was kept on giving analgesics by the nurses. And the patient is now in irreversible paraplegia. The MCI has suspended the license of the anesthesiologist and the gynecologist for 15 days, and other cases are following. This is a case from Mumbai. This is 2019 verdict. TKR surgery, post-spinal hematoma leading to paralysis, multiple complications of paralysis and death. And this patient was a lawyer. But here too, surprisingly, only the orthopedic surgeon has been held negligent, and the anesthetist has gone free. But even then, that may not always be the case. Now, this is the multi-million-dollar question. Who is responsible for the patient once the anesthesiologist leaves? In this case from Gujarat, the anesthetist left, the patient had some breathing difficulties, And by the time the patient came back, by the time the anesthetist came back, the patient had died. And there's 4 lakhs of compensation. So this is really something that all of us need to be extremely vigilant about, that leaving critical patients with juniors and nurses is endangering patient safety, and it can be just held as negligence. In this second case, this T. Padmanabhan versus Hindustan Maternity Home, the allegation was that the patient was not transferred to a bigger hospital or an ICU in time. In this case, again from Mumbai, the anesthetist was not accompanying the patient while transfer, and the patient died at the door, even before the patient reached the other hospital, and that was held as negligence. One must remember that while transferring, the risk, there is definitely a risk of a patient dying en route. And what is more distressing is that the receiving hospital refuses to admit the critical patient. And this is a common trigger of violence and litigation. Non-anesthesia room, the NORA, or the non-operating theater anesthesia practice, is really a quicksand. Here you can see that the Iraqi boy dies during an MRI scan, and 3 doctors have been booked. Now, this Megan Kelly is actually investigating why are children dying in the dentist chair, and she has, it seems, found 50 children who have died in the dentist chair. And of course, the lawyers will be following. Now, this is a very interesting case of Joan Rivers. She is a celebrity. She is a comedian and a TV anchor. And she was being investigated for a change of voice. And a GI scopy under propofol sedation was planned in an upmarket standalone endoscopy unit in New York. Now, the surgeon, after doing the esophagoscopy, said he wants to do a bronchoscopy, for which no consent was taken. He did the bronchoscopy, and the patient had a bronchospasm. The patient later had hypoxic brain damage, taken to a nearby ICU, and the patient dies after a few days. Now, on investigation, they found that there was no intubation equipment readily available. Nobody tried to do a tracheostomy, so there was no scoline available. And what was even more shocking on investigation, they found that the CEO of that unit was trying to take selfies with this sedated actress when actually the saturation was falling. So these are really, really dangerous areas. The procedures are projected as of very low risk. Resuscitation equipment and drugs are not maintained properly, and unanticipated deaths are a sure cause for litigation. Next, most important is the law related to documentation. One has to remember that what is not written is not done. And when negligence has been alleged for anything happening in the OT, the onus of proof that we have not been negligent is on us. So documentation has to be really perfect. If you have poor documentation, it definitely means poor defense. In the first case of Meenakshi Mission Hospital in 2005, there were 2 anesthetists. There was a child for cleft lip surgery. GA was given. She had a cardiac arrest and died. The anesthetist in the OT, there were 2 anesthetists in the OT. The anesthesia records had different time of arrest. The names of the anesthetists was not written in the records, and the hospital has been made negligent. Now, in this case, Apollo Chennai, a patient was to a 29-year-old patient for examination under anesthesia for post-hemorrhoidectomy pain. In the recovery, he has a cardiac arrest, develops multiple complications, and dies. No CPR notes were written, and this was held as res ipsa loquitur, and 57,64,000 has to be paid 1/4 by the anesthesiologist. Corroborating facts with the surgeon, I think, is really, really important, because there are multiple cases where there are contradictory statements about the cause of arrest. Now, in this case, patient was operated for cesarean section under spinal anesthesia, did not regain consciousness and died the next day. At post-mortem, they found 2 liters of blood in the abdomen. Now, the gynecologist said that the patient was already serious on arrival and blood pressure was very low and the patient had PV bleeding. Now, the anesthesiologist said that the patient was fit and normal, and that's why he gives spinal anesthesia. Now, discrepancies in both their notes makes the court suspicious, and both are held negligent. No need to say that fabricating medical records is a criminal offense. This was a very, very high profile case. A very renowned industrialist's son and the best team in Mumbai was in the operation theater. In prone position, the endotracheal tube had slipped out, and it was not noticed till the damage or the surgeon realized. And by the time the resuscitation started, there was hypoxic brain damage, and the patient died after a few days. Now, what they did, this was not held as a criminal offense. What was held as a criminal offense was the fact that they fudged the documents to say that the patient had an anaphylactic reaction to scoline injection. And the police, they had witnesses, some 14 witnesses from the operation theater, and you know how they can take out the truth. So it's best not to fabricate records. And with this, I would like to conclude by saying that anesthesia specialty is a tightrope, and we are extremely vulnerable for litigation. And my thing is that we must learn every lesson that we can take from other people's litigation, because according to Henry Ford, the only real mistake we make is the one from which we learn nothing. I wish you all a safe practice, and thank you very much for giving me this opportunity. Shall I stop sharing?
Yes, madam. Thank you very much, madam.
Yeah, okay.
Okay. Manisha madam, are you there? Yes.
Avinash, I think Manisha madam has logged out because of something. Shall we take the second lecture and then
yes, then expert comment? We will take expert comment last.
Yeah,
okay.
Yeah. So I request Dr. Meenakshi Sundaram sir. Sir, please start with your lecture. Welcome, sir.
Thank you very much, madam. I thank ISA Maharashtra for this wonderful opportunity, that too sharing a platform with the legal luminaries like Dr. Khani madam, Dr. Shivakumar, even Dr. Surekha Shinde madam is a qualified lawyer. But what I want to convey, now madam has threatened everyone that people will be disturbed because that is a routine job of a person who has studied law. They will threaten the people because they will say we may even lose the case. Then if they win, they will get a credit. Just like we say, whenever patient is admitted, if the patient is under dangerously ill list, then we will recover the patient that way. Anyway, at the outset, I thank Dr. Anita Nakate madam for the wonderful introduction. And why there was a disturbance in this first madam was talking is, we thought the topic was overlapping. So the moment I have seen, I was not aware that madam is also there. Really, I was tensed, because whenever we are facing a lawyer, we will be tensed up. That way I am tensed. So I called madam straight away what she could. Then she said, she was so innocent. She said, I will send all my presentation to you, then you go ahead. I was very happy. This is just like what is happening even in the court of law. Sometimes the two lawyers, they will collude together and they will kill the third party. Same way we have colluded, but for the benefit of the audience. So I said, whatever madam talks, I will not talk. That is the first thing we have analyzed and we have agreed. So in that way, I have not touched upon that factor at all. Then I was thinking what I have to say. Madam is a walking encyclopedia regarding law. So she has finished everything. And I am happy. Just I have seen that presentation. Then I thought at least Madam has given a loophole for me. And as I said, I have for every case, I will have a out of box thinking. That is the reason why my presentation will be different. So now I will make you all convinced that it is very easy to practice even in the draconian consumer law. So what now I am going to say to the audience, how to convey the bad news, then medical legal aspects, not covered by madam in my way, and what you have to do if you receive a legal notice, and what are all the information which we should know when we are preparing a counter affidavit, that is when we are defending our case, then what are all the protection schemes available. So as it is a legal platform, like any other lawyer, I am saying this is only for teaching purpose, this is for discussion purpose, and it should not be taken as a substitute for seeking competent legal advice. Because if you follow my suggestion and if you are getting caught, you are not supposed to sue me for the damages. So at the outset, I am projecting it as a disclaimer. This is my view only. So how to convey a bad news if something has happened like perioperative problems or perioperative death, how to convey the bad news. Now, maintain an eye contact with the relatives because the patient is already gone. You cannot maintain an eye contact with the patient. So you maintain an eye contact, appropriate eye contact, that is must. So whatever may be your position, even in day-to-day administration, we have to maintain eye contact to whomever we talk, that is must. Then more than eye contact, gestures are also important. So we are not supposed to ignore the gestures, which may be the hidden gestures. We have to be very careful. Then communication is important. In communication, I want to stress that while you are communicating a mishap, it is only 7% words. The attenders will not listen to the words. They will listen to the tone, accent of our conversation, and mostly the body language. That is important. So what I am saying, even though day to day we may be seeing death, but while you are talking to the attenders, you should appear to be upset. That is important. Whether you are upset or not, you should be appear to upset. Then you have to use your body language in such a way that you are really concerned about the loss. That is important. So a good communication and a wife, see, even without a tire, the wife balances. So this is only imaginary because no wife will bring balance in life. So a good wife can bring balance in life. Same way, a good communication will bring balance in life. When you want to break a bad news, you remember the spikes as a mnemonic. These spikes will be set. These spikes will be the settings. It should be large enough to accommodate the good people, attenders. At the same time, it should be small enough not to accommodate bad people. You cannot create a big gathering. And if whenever the assault is there, it will be very big. So the space should be a reasonable space. And you perceive what the attenders want to listen. You invite them courteously. Then you have to explain the events in a local language. That is important. We cannot use medical jargon while we are explaining the mishaps. Then you acknowledge their emotions and agree for the next step. So that the spikes is necessary. And I want to tell you, anyone can help in communication, both living and non-living things. So we have to have the ambience, a good ambience when you are explaining things. So when the mob is angry like this, that is the approach. Good nurse is needed, but this nurse will be a diversion. But that nurse is only a mnemonic. Nurse means name the emotion. It seems you are angry. You have to talk like that. Then you understand their emotion. You have to accept that we know that you are really upset. Then the best thing is you have to respect and you have to praise the patient if he is alive. You have to praise the caregiver if the patient is not alive. We have to say that you have helped him so much, because then only he will pay the hospital bill. That is important. So then you support them, explore what best could be done after a mishap. And responding to anger, I want to tell, when under the name of multidisciplinary approach, when multiple opinions are sought for a patient, when there is a mob, this is just like this patient becomes a doctor and the entire mob will assault the doctor both physically and mentally. So what you sow, you will reap. So to avoid medical legal problems, always be kind to the patient and the attenders. And whenever the angry mob is there, don't be defensive and don't take it personally. Listen to it, because anger is a coping mechanism. All psychologists will say anger is a coping mechanism. And after 2 or 3 hours, that anger will wane and they will appreciate the doctor. But set appropriate boundaries for safety, that is important. At the medical legal aspects, the second point in my aim, I think there is a lot of disturbance. The legal notices against the doctors are steadily rising. As Madam pointed out, 400% increase. So the doctors, instead of attending routine CME, they have to update medical legal knowledge also. That's what we are doing. But always in medical legal parlance, prevention is better than cure. So why there is a problem? Doctors are having a stigma of meeting police and lawyers. They are not going to the police station as a friend. They are not going to the court as a friend. That stigma should go. So you have to have so many friends in police and lawyers, at least in your jurisdiction. Then the doctors are ignorant mostly of the law of negligence because they concentrate only on medicine. And unfortunately, the legal people don't understand the intricacies of anesthesiology. And another problem, the law advocates, they rely on textbooks. We have to know we are reading Western textbooks, but we are treating Indian patients. So whatever is read, it cannot be practiced. But that gap will not be accepted in the court of law. That is the reason why more cases are there. So the Indian doctors, they have to write books according to the Indian standard, and we have to create the guidelines. And there is no definite law for each and every problem. I want to say this line because Madam has pointed out so many cases where the doctors are punished. I will give so many cases where doctors are acquitted with the same problem. So no definite law for each and every problem. The judgment is decided by the judge, that particular judge. That is, so it varies from judge to judge. And most of the time, the judge is a non-medical man. What I want to tell you, when a doctor witnesses a scene like this, he is very active. He may even see a pupillary reflex like this. He is active in others' crisis. But when it comes to them by legal notice, they want to run away. So I could not understand when they should be active in that crisis also. So what lessons we have to learn? Madam was talking about the consent. So I will also touch upon that consent. What is the informed consent? What is the implied consent? Informed consent, we all know. We have to explain everything. But implied consent, if the patient is unconscious, see, these are all the areas where consent is not required. So the medical emergencies, even the court says in medical emergencies, life-threatening emergencies, the medical consideration takes over legal considerations. Same way in notifiable diseases like cholera, this COVID, typhoid, everything, here the nomenclature is the legal considerations takes over medical considerations. And these are all the areas. areas, immigrants, members, these are all the areas where consent is not required. And we have to know at the request of police also we can administer anesthesia. It also comes under no consent required. At the request of the police means it is by the court of law. The implied consent is if the patient is coming like this, then we cannot wait for taking a consent. But what I want to say, once the emergency treatment is no longer required, the doctrine of implied consent does not govern. This is what happened in Samira Kohli case, where madam has projected that thing. Samira Kohli, they have commenced that diagnostic laparoscopy, but at the diagnostic laparoscopy there was endometriosis of uterus, so they have done a hysterectomy with the bilateral oophorectomy. That lady is aged 48 years, I think 48 years. She sued, I have lost my uterus, I am still unmarried, so I will have children. So he has sued so much, but the court said the doctor is at fault, but they have asked that money collected as hospital charges should be refunded. So in that way, the court was kind to the doctors. But once the emergency treatment is over, especially in multiple injuries, road traffic accidents, if the head injury is treated, consciousness returned, then implied consent will not come into picture. So as madam was talking about that post-operative pain relief, for post-operative pain relief, they have to take a consent. Means what I want to convey, that may be dreadful, thinking that for every post-operative thing we have to have a consent. So this judgment was delivered in 1993, even though it was long back, as the Western judgments will be followed even in Indian courts. Why I am quoting this? If suppose by oversight, that's what I am going to do in future cases also. By oversight, if you have missed that consent or everything, you should know how to defend yourself in the court of law. That is a positive approach. First thing is prevention is better than cure, but something has happened, how to come out? We have to quote some judgments which favors us. As I said, judgment varies from judge to judge. So we have to take points from the judgments which are favoring the doctor. So this Lord McCullough, he has given so many judgments favoring the doctors. Here, GA consent was taken, but a post-operative pain relief caudal was given. So there was a persisting numbness of left leg. So the complainant filed a suit against the anesthetist, but the judgment was this would amount to sectionalized consent. It cannot be like that. If one is to treat administration of injection for analgesic purpose, this, if at all like morphine or anything, then every step consent cannot be taken by the doctor. So the judge made a remark in that case. How long will it be before the court is invited to say that a separate consent should be sought for separate steps in surgery? Like the surgeon is getting a consent for doing herniorrhaphy, he is not getting a consent from incising the skin, incising the subcutaneous tissue, incising the external oblique, whatever it is. So this judge is a good judge. So we should not be carried away by judges like this. This judge is like this, but most of the time the judges will be like this only. So we have to be very careful. We have to know the mentality of the judge. As madam quoted this Aruna Ben Kothari case, the apportion was 60% anesthesiologist, 30 ortho surgeon. What I thought that madam, I have seen that madam's slide, so only I thought, see, imagine the share. If the surgery was successful, anesthetist will be taking 10%, ortho person will be taking 30%, and 60% will be by the surgeon. So we have to note this point also. And then madam said artificial ventilation. If ventilator is not there, the doctors were punished. But now I will give you the example. In Mumbai Grahak Panchayat case, they only said, as madam pointed out, not having a ventilator in OT amounts to deficiency, right? Accepted medically also. But in Karnataka Consumer Dispute Redressal Forum, a doctor argued there was a Boyle's machine, and a Boyle's machine, with the Boyle's machine, I can ventilate the patient. So a automatic ventilator is not needed. So there the doctor was acquitted. So if suppose something happens, you can take this as your defense argument. The same way, see, the team of doctors opined that 100% of oxygen was sufficient. So ventilator was not summoned as it was necessary. See, when the patient is suffering from ventilatory failure, administration of 100% oxygen, like most of the non-anesthesiologists will be doing in that particular point of time, I request all the professional colleagues, please don't argue medically in the court of law. We are not supposed to say when there is no ventilation, what is the use of giving 100% oxygen? We are not supposed to say like that. The team of doctors opined 100% oxygen is sufficient. So what I am stressing, you have to take a clue. As it is an open forum, I cannot say any further. Please listen. The team of doctors opined 100% oxygen is sufficient, so ventilator is not needed. Even judgment is like that. So as madam said, the perioperative patient, the cardiac arrest patient not intubated. And once the anesthesiologist was acquitted,
Varsha madam, please see who is his microphone is on. Please mute. Yes, sorry, sir. Please continue, sir.
the cardiac arrest patient not intubated, but the anesthesiologist was acquitted. It is a case of fallostrategy operated in the post-operative period. Fallostrategy not for that complete correction, for incidental derangement. The anesthesiologist was acquitted because the pediatrician said he would not intubate and will only observe the child. So this is also a case where the anesthetist was acquitted. So as we know, the monitoring standards are so many. Even the anesthesiologist has to monitor the patient even during transport. Madam mentioned that. So what I infer from her lecture, anesthesiologists can have monitoring benefit, but not monetary benefit. We have to think. But one point, informed consent we were talking about, but informed refusal we have to know, because informed consent may be even oral. We can argue in the court of law, orally accepted, not in a written format. But if there is an informed refusal, if suppose the patient refuses spinal anesthesia, it should be always in a written form, because we have to prove the burden. Madam has mentioned about delegation of cases to juniors. Yes, it is a punishable only, because there may be minor surgery, but not minor anesthesia. So the court demands the delegation only to the competent persons. The court says it should be given to the person with the same skill. Average skill is enough, not like the highest skill. Same way in institution, people will be routinely asking whether PG can monitor it separately. PG has to learn, but the law requires this only under supervision. But here I want to tell one point. See, we are not supposed to say a qualified person only should give anesthesia. Qualified means MD qualified, anesthesia qualified. The court says it has never mentioned about the qualification. It says the skill. The wording is different. You should possess the skill to administer anesthesia. We have taken it as a qualification. Both are different, because the Supreme Court mentioned you can be taken to the court on two counts. One, by not possessing the skill which you have professed to have possessed. Not possessing the skill. It is not mentioning about not possessing the qualification, not possessing the skill. And number two, if you have not exercised the skill in appropriate time and with the average skill. So we have to note that. So if suppose a PG has monitored, something has happened, we can say as a MBBS graduate, he can practice medicine, obstetrics and surgery. Anesthesia comes under medicine. So the compensation, I'm telling you few judgments. Compensation awarded for perioperative cardiac arrest in a fit heart, because cardiologist has mentioned it's a fit heart. But the specialist opinion saying that oxygenation was improper during cardiac arrest in spinal anesthesia, neurophysician. So compensation was awarded, right? This is true. But while transferring the patient, Madam was talking about transferring the patient. So the Supreme Court said the duty of the doctor to render all the help. So Supreme Court demands you have to receive the patient, stabilize the patient, then only you have to refer. So odd times you are not supposed to refer. And now in Maharashtra Consumer Dispute Redressal Forum only, The patient was transported in an ambulance, but oxygen was not there. On the way, oxygen cylinder became empty. So they were charged 4 lakh, punishment was given, and award was 4,10,000 because the ambulance was not having adequate amount of oxygen. This is Maharashtra court. But the Kerala Consumer Court, there one doctor transferred the patient in an ambassador car to the hospital. Then the complainant has given the complaint, the doctor has transferred the patient in the car, it is negligence. But the doctor argued in the car, he has appropriately applied suction to clear the oropharyngeal secretion, and he was carrying an oxygen cylinder in the car, and he was administering oxygen. So the court acquitted the anesthesiologist. Here punished, here acquitted. So what I want to say, even if you are transferring a patient like this, you please say you have applied a suction, you have applied given oxygen. In that way, it may be a good defense. So what lessons learned? First, treat the patient. If not possible, manage the relatives because the patient has gone. If not possible, treat and manage the case sheet properly. If not possible, be ready to pay whatever you have earned in the previous years. So to avoid litigation, never be angry with the patient. Don't charge too much. Don't insist on fees if you expect a problem. Here I want to be very cautious. Don't insist on fees if you expect a problem, but never leave the patient free of cost, because then the attendants will think some mishap has occurred, so the doctor has not charged the fees. So explain everything without any bias. And if you receive a legal notice, in spite of that, if you receive a legal notice, first accept the legal notice and relax for some time. Be cool. Don't discuss about the notice immediately with your professional colleague. It may create a negative impact. Then read the notice carefully several times. Find out the charges of negligence point by point. Select a good lawyer who can understand medical intricacies, as legal knowledge alone or medical knowledge alone would not help in the court. So if you receive a legal notice, impart as much medical knowledge as possible pertaining to that particular case, because no extra discussion with any lawyer, because the medical knowledge acquired by your teaching may be used to trap any of our professional colleague. Worst, sometimes it may be even us sometime later. So you restrict your discussion pertaining to that particular case. Answer each and every charge carefully. Even if it is a false allegation, we have to say we are not accepting the charge. It is always better to begin the reply. I am denying all the allegations leveled against me in the legal notice, except which are admitted hereunder. That is a routine statement even the lawyers will make. So any omission in this will amount to acceptance of the charges. Then we have to read the notice, whether it is a civil or criminal negligence, we have to answer appropriately. But the reply notice should be carefully drafted, because it is a foundation on which a building is going to be built. We cannot add or delete a point from reply notice till the final phase. So we have to be very careful and never prepare a reply notice on your own without consulting a lawyer. That is the important, because as we know, self-medication is always dangerous. It is applicable for law also. So if you receive a legal notice, read the case sheet several times before attending the court and get yourself prepared for the case. Madam mentioned, never tamper the case sheet once the legal notice is served, because a Xerox copy of the case sheet may be already with the complainant. Nowadays, even with the mobile camera, they will take a photograph. So once the case sheet is tampered, there is no proof for us to defend. So we may be charged extra, because first we would have been charged for omission, and by tampering we will be charged for commission. So if you receive a legal notice, be calm in the court. Don't be confused. Then the prosecution lawyer might be trying to irritate us by unwarranted questions. But we have to be quiet by mind and not by mouth. We have to be very careful. This is important. And mainly, never irritate the judge in the court. So that irritation of the judge may be due to the talking so much irrelevant, or keeping mum without revealing anything, both will irritate the judge. So if you receive a legal notice, I request all of you, please never go for out of court settlement. I have received many notices. I have won all the cases. Never go for out of court settlement, fearing our reputation in the society, because in my personal view, if a doctor has not received any legal notice, he may not be a practicing doctor, or he may be a PhD doctor, non-medical doctor. So if you want to select a lawyer, it is good to select a lawyer who knows law. Better to have a lawyer who knows medicine, but it is always the best to have a lawyer who knows the judge. Don't take it otherwise. I am mentioning about the mental makeup of the judge, because some lawyers know how to argue with a particular judge. So you have to know that. And now I will be just rushing to tell you there are so many defense, what we have learned from judgments. The defense will be this Jacob Matthew case. You have to remember the Jacob Matthew case in a nutshell. It says negligence on the medical side should be treated differently. These are all the words we have to use while defending the case, because the moment the word Supreme Court is there, at least the people will be disturbed. And most of the time, the lower court lawyers, they are not aware of these judgments. So if you mention Supreme Court, they will be very much worried. Your Supreme Court said a simple lack of care or error of judgment is not a proof of negligence. And here I want to say, so he cannot, so long as a doctor follows a practice acceptable to the medical profession, he cannot be held liable for negligence. And again, if there are two methods of treatment available, if one treatment is followed, it is also not negligence. And a professional, as I said, there are two counts. He was not possessed of the requisite skill, not qualification, which he professed to have possessed. Yes, he can be taken to the court. If he is not exercising the skill which he professed to have acquired, that is also negligence. But here I want to stress, the standard to be applied for judging is a comparison with the ordinary competent person exercising ordinary skill in that profession. So I should not be compared with Pratibha Khani madam or Avinash Bhosle or Manisha madam. Ordinary person, I should be compared with the ordinary person, so that you can file the case in the court. So it's ordinary only. Then the court mentioned necessarily the treatment should be different. Court has mentioned there is a marked tendency to look for a human actor to blame for an untoward event. So while you are defending, you have to quote these lines. That is the reason he is filing a case. So the court has mentioned sometimes the doctor may not be at fault. There may be a chance error in which the doctor's contribution is either relatively or completely blameless. These are all the words we have. Then they have mentioned this word I will routinely use in all my reply notice. The human body and its working is nothing less than a highly complex machine, which a non-medical person cannot understand. All my legal reply, this will be there. So as per the Supreme Court order, then the Supreme Court order, but in spite of saying all these things, the Supreme Court cautiously remarked, we may not be understood as holding that doctors can never be prosecuted for an offense. So that they have mentioned there is a need for protecting doctors from frivolous or unjust precautions. So in this judgment, they have mentioned if the patient dies during surgery, it cannot be automatically assumed that the medical professional was negligent. This is also a Supreme Court judgment. There should be a material available on record. Madam stressed, if there is no record, then it is punishable. So the negligence alleged should be so glaring so that the res ipsa loquitur can be applied. The Supreme Court has clearly mentioned a surgeon with the shaky hands and the fear of legal action cannot perform a successful operation. Applicable for anesthesiology also. So the medical professional is there to help the patient only. And this judgment was also I will use. This is the happiest judgment which we can ever see. Whenever you receive a legal notice, in that case, Martin F. D'Souza case, the court has mentioned before issuing a summon to the doctor, the case should be referred to a medical board. Then only prima facie evidence, if it is there, then notice is to be issued. So all the legal notices which I received, I will say like this. my reputation will be at stake. So before asking me to appear before the court, you please form a medical board and find out where exactly I have erred. So that way, that consumer forum should refer the case first, should refer the matter to a competent doctor or committee of doctors. So this is a good thing I was doing. But 4 years back, Justice Ganguly Court, it has overruled the judgment. But if the advocates are not aware of this, we can even quote that you have to refer to the medical board only, because here that Ganguly bench judgment said that the discretion is left to the members of the FARA. There should not be any straitjacket approach, because what they have done, a case of malaria was treated as typhoid. At that time, the doctor argued the case was not referred to the medical board. But that judgment said, see, it cannot be sent routinely. Whenever a person operated on the left leg instead of the right leg, why should we refer it to the medical board? So when there is a doubt, we will refer to the medical board. So as the judgment was overruled, it is there. So the FAR, again, even if you are giving an expert witness, the court is not bound in every case to accept the opinion of the expert witness. That also we should know. So the professional indemnity insurance schemes, PPLS is there. They will even file the affidavit, the counter affidavit. So, but most of the time, the advocate, I have seen 2 cases, the advocate prepares the counter affidavit and it sent it to a doctor concerned for signature. But the doctor, thinking that it is a proof correction, he will see that and he will send it immediately by post without signing. That is the reason why I say, please sign and send it to the complainant. If you are not a member of PPLSS, you join the PPLSS scheme. That is really an advantage. And in ISA, we are having indemnity insurance called Cover You. It is outsourced. So you can go for that also. So in a nutshell, the carry home message will be doctors and the snakes are respected by public out of fear. But whenever there is a chance, both would be beaten. We have to be very careful. And lawyers and the public are dancing on the shoulders of doctors. They are harassing us even for flimsy reasons. How to avoid this? To avoid litigation, be friendly with them. Always be friendly. That is better. And so by being friendly with them, avoid litigation and enjoy life. I thank ISA Maharashtra for the wonderful opportunity. Your Vice President ISA National is there, your President is there, and your Secretary is there. Everyone is here. Deshpande sir is also there. So I thank Maharashtra for the wonderful opportunity and allowing me to have a length and breadth of Maharashtra. Thank you.
Thank you very much, sir. Very good presentation, sir. And there is one comment, compliment for you. First time I didn't get 2 stages after listening to a medical legal talk, which usually happen.
Bachchan
It was an excellent talk, sir. It was excellent talk by both the speakers. But we would also like to listen to our chairpersons, Madam Anjali Madam, Surekha Madam, as well as Savargaonkar Madam. Can you please make the expert comments on both the talk?
Yes,
After
Manisha
that,
Madam.
we will take question and answer.
Yes, Madam. Anjali Madam.
Both the lectures by both the speakers, Pratibha Madam and Meenakshi Sundaram sir, great lectures. Both of them have, by quoting the actual litigations against anesthesiologists, passed on the message, appropriate message to the audience. And the very important was the how to prevent the litigations, and then Meenakshi Sundaram sir has very nicely explained about how to offer the defense. So that's great. That's great. The things what I gather from both the lectures, that following the good practices, first thing, by following the SOPs, standard practices, and our own protocols to be followed in the OT is very important for preventing the litigations. A simple example I will tell, that if you follow protocol, that the person who is administering the drug intrathecally, if that person himself or herself checks the label of the drug. So many cases inadvertently injecting the wrong drug can be prevented. So this is the importance of following the protocol. So following the good protocol, good practices. Another important thing is the documentation. I had been in many inquiry committees because being in the government service. So documentation means medical record only for yourself whenever there is any litigation against you. And of course, as Meenakshi Sundaram sir said about the communication, it is not only the communication, it is the skill of communication should be actually practiced. The only thing I wonder that from the Pratibha Madam's lecture, that in one of the cases, the anesthesiologist was held responsible for keeping the mop inside the abdomen. That is, I really don't understand how the anesthesiologist can be held responsible for this. But otherwise, yes, both the lectures were really great. Thank you, Pratibha Madam. Thank you, Meenakshi Sundaram sir.
That is a fact now. They are just holding the whole team responsible. And the more the number, the more chance they get. That's what they feel.
But
Madam, whenever there is a
difficult
problem,
to digest, no?
no. Whenever there is a problem, the entire team will be sued. There is no way of doing it. It means you are helping the other person to create the crime. You are helping, so the team will be responsible. And another pity in that, the staff nurse is responsible if she is qualified. If she is unqualified, she is not responsible. Only the hospital is responsible.
Correct.
See, this is a problem really, madam. Whether we are able to digest it or not, we want to present. That is the reason every time I used to say, please don't imagine or say that we are in emergency. We are not creating. We are not the judges. For example, I was defending a Maharashtra case. I was defending that a lady anesthetist got that problem. So I met the husband. That husband approached me. Then I was seeing the case sheet. There is no pre-operative assessment notes. I casually asked, sir, there is no pre-operative assessment notes, sir. What can I do? He started shouting at me. He says, sir, you tell me one anesthetist. He quoted his area. You tell me one anesthetist in my place who is writing the pre-operative notes. I said, Sare Baba, why you are shouting at me? I am not the judge. I am here to help you. But nobody is writing. I accept. But all the other people escaped. Your spouse was getting caught. Even now we are arguing. We are in emergency. We are there. We are there. But so many flimsy judgments I know. In Tanjavur, there was a judgment. The case was not managed properly, government hospital, because the case sheet is written in different inks. Different ink means what? House surgeon will write it with one ink and PG will be writing it with another ink. That is a problem. Same way, another judgment, the case was not managed. It is mentioned, it was seen by nephrologist, cardiologist, everything. But there is no signature of the doctors because the house surgeon is writing the notes. So many. So we have to change. It is very difficult to change the system. We have to change.
Yes, agree.
Sir, here
I
would
want
like
to have one more comment here. Madam Savargaonkar said that anesthetic is not. It is now international safety goals and WHO also says
Correct.
that anesthetic
You
is a
have
part
to
of
do
the team. So
guidelines
the
of
whatever
NHS has
now
to be
The time out.
it has to be practiced. Sign out.
Yes, sir.
Time out is the last day where anesthetist has to be vigilant. Everything is proper.
Count should be taken of everything.
Count should be taken
Yes,
in
that is
presence of
still now
Yes.
we used to consider that staff nurse is supposed to count, and finally, yes, then
Yeah.
anesthesiologist
Yes.
should see as a timeout that the mops have been checked
Yes.
by the anesthesia staff nurse who is assisting
Madam,
the.
Yeah, it is one of
So
the
that we
points
have
in
to
the
then again now follow in our practice.
Yes, yes. Madam,
We'll
in
go
fact, it is
to-
one of the
actually,
points.
timeout
Yes.
It is in fact
So-
one of the point in the
Timeout has
WHO
to be
physical safety guidelines.
done by all surgeon, anesthetist, as well as the nurse.
All of them
Yes.
have to sign. Yes.
Okay.
Yes,
All
we
of
will
them
One
do
of the
are responsible, surgeon,
Yes.
anesthetist, and a nurse also.
it is
For
one of the
timeout.
point in fact in the WHO surgical safety
Yes.
guidelines. So
Yes.
the WHO surgical safety guidelines has to be followed. By all
Followed.
of
Yes. Now we will listen to Sureka madam.
Yes, sir. Thank you so
Yes.
much. Both my seniors, Khani madam and Meenakshi Sundaram sir, thank you so much for giving us such a nice overview. And Khani madam, I really appreciate for opening the Pandora box. It was real, I would say, a very frightening thing to know on what grounds we can be sued. One thing I want to stress upon here, because with different advents of different gadgets, drugs, anesthesia outcome has become quite predictable and favorable. But on the other side, with different skill sets, we are stepping out of our comfort zone of operation theater. So naturally, we are more vulnerable for more and more cases. So what should be done? Because see, we have to approach catch them young policy. As a senior faculty from government hospital, I think my take-home message is we should sensitize our students, the residents, right from day one. So every year we are having medico-legal seminars for students. We are making them aware.
Very nice.
See, in 3 years, they're quite under our care and they're just protected. But once they step out of the comfort zone of in the society, they're just thrown out. So we have to make them aware of the checklist, about the protocols and where things go wrong. We have to tell them to approach a person whose expertise when they land into any problem. So all these things should be taught them right from the beginning and not when they actually face the problem. So this is a take-home message for all faculties in government hospitals or any, I would say, teacher. The second thing is, I think we should have the scenario-based learning for them, like problem-based learning or skills, the way we have in DNB also. So we have to create scenarios, not to frighten them, but to have their policy. I mean, what will go wrong in my practice and how do I approach it? And the same thing, I think Meenakshi Sundaram sir has told us. He has really very smoothly walked us through when we get the legal notice, right? So it was wonderful, sir, to know how we can really face the litigation. I mean, we can relax, we can be calm, we can be quiet, and then we can approach whatever problem is that. It was really wonderful. One more thing here, one question, I think. Suppose a person, we talked about Ayush, but I know a person in Pune city who's practicing obstetrics for last 30 years. She is diploma, not given exam, so literally doesn't exist. But she's practicing very nicely for last so many years. So when anesthesiologist is associated with this surgeon, if any legal notice comes, so what is the stand in the court of law? She's practicing.
See, we just had one case where the Dr. Deshpande, he had gone. He was he was a proper trained anesthetist. He's gone. Now, in that case, at least he has been absolved. But we don't know. Like I said, that the new NMC is trying to bring some, some points where they will say that we should not. Up to now, there is no guideline which has come, but the new NMC, I have just heard that they will put this as one of the, your so-called moral obligations or something like that, that we expect our members not to.
And one more thing, madam, just now I'm preparing for one of my seminar in, on medical legal and awareness during anesthesia as a PG program in BJ Medical. So regarding awareness, we have many litigations abroad. Is there any scenario in Indian context of awareness and anesthesia?
I haven't found. I really haven't found. But overdose of anesthesia, there are lots. But awareness probably, no, I haven't. Not
okay, then I can definitely quote you tomorrow when we present.
I haven't. Yeah, because I do read a lot, but I haven't. I was trying to get it.
Can I say something here?
Yes,
madam.
madam.
Yes, madam.
Rekha,
Yes,
even though
madam.
there are no litigations
Please.
about awareness, there is incidence of awareness in our
Yes.
country. No
That is
doubt
true.
about
That
it.
is true. I'm talking
That is
about
true.
the court case is happening about that.
See, we are not, probably even the patient doesn't understand.
Exactly.
Because
our scenario,
abroad, yes, because abroad they're very aware of, trauma, all these psychological
No, but
things.
Pratibha,
Probably
the
our
time is
ticket.
not far from now that
Yes,
there will be litigations even against awareness in our society.
correct.
Yes,
But
yes.
we've never really addressed mental issues so openly. So people just think that maybe, the dreams are coming, or that disturbance is coming, but it's all right, it's part of the post-operative recovery.
Yes.
Hello.
Yes.
Yeah,
Who
yeah.
is speaking?
This is Dr.
Yes,
Shivkumar
sir.
from
Shivkumar,
Karnataka.
sir. Please.
Yeah, my special compliments to both the speakers. It was excellent. But as per my knowledge, even if they're trained for decades together, they cannot give anesthesia unless they have a qualified degree. Even if they have a qualified degree, they should be registered in their respective medical councils. Okay. In Karnataka, one case was so happened. Okay. He had not registered his post-registration in the medical council. When the legal notice or inquiry went upon, and as per records available with the medical council, he is just a MBBS. He is not qualified to give anesthesia. Something they replied. So in these cases, whoever gets the degree, they should be registered in the respective medical council. Then only the authenticity will be there. I think this is what happened in Karnataka.
Sir, then there is one question here. Is the third poster, the JRC, can he give the anesthesia independently? Then as per what you have said, he may not be able to give anesthesia independently.
No, you cannot.
You cannot.
Basically, you cannot. I don't know what Dr. Meenakshi Sundaram will say, but
Madam,
I would say he cannot.
Madam, the chairperson has to point out the question to which speaker it goes. Then only because we don't want to interfere. Because in any medical session, there are two possibilities. One is education, another is entertainment. So for education, Pratibha Khani madam is there. For entertainment, I am here. So if you ask me what I am saying, a third year PG, see, legally, if it is asked, definitely we will say no. But what I want to say, sir, there are interpretation is different. See, even the court says, if whether you are skilled or not, this is court. I am not saying that. I am not saying, yeah, surgeon can give anesthesia, not like that. Anesthesia should give anesthesia. Even for our safety also, we have to say like that. But court says if a MBBS person is giving anesthesia, if suppose imagine a MBBS person is working in a medical college in the anesthesia department for 12 years, then the court accepts that. That's what I want to say. You cannot simply by that first one line, it cannot be cut. It first by one line, he is not qualified to, because whatever consumer court notices I have received from my personal experience, I am saying, as I was managing medical care, all notices said, this man is qualified only in anesthesia. He cannot take this gastroenterology case. One case of rupture esophagus bronchopleural fistula I treated. It should have been treated by gastroenterologist. See, those people have seen. I was the primary consultant. But even then, every time I used to write it the defense as a MBBS, we can practice everything. It is only by experience, other things come. All over the world, the anesthesiologists are managing a critical care unit. So critical care unit is the stabilization of the milieu interior, which is the normal working, everything. What I want to say, whether it is right or wrong, I am not here to say what I have done. If you are getting caught means, see, nothing is intentional. The anesthesiologist, whatever they do, it is not intentional. Yeah. But if something happens, you have to defend yourself. I have given you the clue. Even I have received a mail. One person was sent a mail to me. How long you will protect these delinquent anesthesiologists who are careless? See, whenever I'm getting, even now I have put up a chat box. If you mail me, I will prepare a counter affidavit. I can guide you in that. It is free of cost only. It is my, just as a hobby I am doing. But what I am saying, if suppose you are caught, I am not saying anything right or wrong. I am not here to say you junior anesthetists can do, MBBS can do. That's, I am not saying that. Same way, even in the Ayurveda, Kraspati is banned by the Supreme Court. Banned. But that Ayurveda persons only in Maharashtra, they are having a license. I discussed with Pratibha madam also. See, it has been mentioned within the syllabus covered, they can practice modern system of medicine. But now it is a friendly appeal to the anesthesiologist. Please don't encourage cross-pathy surgeons. It is always better.
Okay, thank you, sir. Yes.
Sir, it's a very good take-home message, sir.
Yes.
In the area where we practice, there is one hospital which is entirely Ayurveda hospital. It's a big charity hospital. Except anesthesiologist, everybody else is an Ayurvedic obstetrician, Ayurvedic surgeon, and this MD anesthesiologist, they work there as a consultant. So I think we should be telling them, okay, just please ban. I mean, if you, they will be
lucky. Start tweaking your practice that it may not, kind of go well if anything happens.
Yes,
that's what like
May
sir
I
said.
add something here? With the permission of the chairpersons and the speakers.
Madam, yes, you are most welcome, madam.
See, there is something, Pratibha, there is something like a locality rule. So if a person is practicing in an area where there are practicing anesthesiologists who are officially, who have got training and who have certificates, then in such an area, if a person who is not certified can be held liable.
Madam, shall I answer this question?
Yeah, sure, sir.
Yes, because in Tamil Nadu, now I have seen a question in the chat box also, with the 3 months anesthesia training, can they give anesthesia for LSCS? Tamil Nadu, we are having 6 months course training. As a chief anesthesiologist, I was teaching that MBBS trainees who have come, but in the national general body as an anesthesiologist, I appealed. This system is to be scrapped. So when we have 2 rules, we have to do justice for both. But in Tamil Nadu, this problem came and the High Court ruled. This is only for emergency under the program called CMANC. So it has mentioned.
For emergency, anything is accepted. But the question is if it is for a routine case.
Yeah, no, that's what I am saying. I am not making a comment on that. I am telling the High Court judgment. The judgment ruled the person can administer only anesthesia only in that hospital, and if only for obstetric cases, only if it is an emergency. This is a court ruling 3. Only in that hospital. If suppose I am trained in Trichy, I cannot give anesthesia even if it is an emergency in Maharashtra. The court has mentioned. Again, if there is any deviation in practice, like assisting Ayurveda for earning money, everything, they are doing at their own risk. We just tell them, if you getting caught, you will be punished. It is applicable for this. The trained doctors, they cannot give anesthesia legally in all the areas. But most of the time it happens, means let it happen. Every time thieves will be there, madam. Police also will be there. So only if the thieves change on their own, there will not be any theft. Till that time, it will be like this only. It is a system.
True.
Yes. Yeah. It is like that if there is no neurosurgeon in the town and if the general surgeon do the craniotomy, it is acceptable.
The life-saving procedure. So,
yes. So like that, if anesthesiologist is qualified, anesthesiologist is not available, and if MBBS person gives anesthesia, then and if anything goes wrong, what will happen?
In emergency, it is always acceptable.
Yes. Okay.
Means there at least it can be defended that the lady's life was at stake.
Yeah, it's ultimately about defending. It's ultimately about defending. And you have to call up Dr. Sundaram and say, sir, I have a problem.
Madam, I am very much willing. Madam, I am very much willing. Certain things cannot be shared in the open platform. I will put up a mail. I will be always willing to prepare a counter affidavit. There are so many ways of defending. See, once some problem has happened, what else we can do? We have to defend. Whatever.
Defend, yes. That is true. No, either you prevent or you defend.
Dr. Bande.
Yeah, sir. Good evening.
Good evening, good evening. Meenakshi Sundaram, nice lecture again, once again.
Thank
So
you.
I had just one comment regarding this cross-pathy.
Hmm.
See, 2018 MMC has filed a petition in the High Court because Maharashtra state allows the cross-pathy by rule, which is necessary because there are not enough practitioners across the rural areas, etc. So this is still pending in the High Court, but according to Supreme Court, as you correctly said, the cross-pathy is not allowed. If the case reaches by any chance beyond High Court and Supreme Court, it will not be acceptable. There will be a clear-cut judgment against, no matter who practices what.
Correct.
So MMC petition till it is handled and judged by Mumbai High Court, these things will remain in gray zone. But the safety lies in having appropriate behavior where cross-pathy should be avoided as much possible. Thank you.
Clear cut, sir. Excellent.
Pratibha, may I ask you one question?
Yes.
About awareness, when we talk about informed consent, do you think that the chance of awareness should be included in the informed consent?
You can't, I mean, like, it is an aberration. So you can't, I mean, what I mean to say is that there is, you can explain awareness. I don't think I would like to take any consent for awareness. But yes, if there is some kind of a emergency, trauma, obstetrics with, very low hemoglobin, patient in shock, these patients, it's easy to defend afterwards. But I don't think I'll take a consent for it.
Mainly, madam, for obstetric cases,
Avinash,
because most of the cases are on obstetric point of.
If you are giving GA,
they are feeling the awareness.
Avinash,
Usually in shock.
Yes.
See, you have to defend that they are in shock and
It's not immediate threat to life, awareness. Maybe
Yeah.
there are certain other complications which are not detrimental to life. So it's
But
okay.
if you are in America, you have to explain that you may get awareness. So it's just a way of, how much you want to inform and what kind of a patient is there. There are many patients who actually ask about awareness. They say, will I, wake up in the middle of surgery, especially if they've seen too many movies, or nowadays everything is available on Google. So they do Google and ask. Some patients do ask, will I get up in the thing? So you just have to say that you are not expected to get up unless, your blood pressure falls or something. Unless there is some
a gray
safety
area
issue.
regarding how much to explain regarding the risk and complications while taking the informed consent.
I mean, it's very
very clear.
surgeons, ma'am. I'm working in orthopedic surgeon in BJ. When I start explaining problems with surgeons and residents, I have a directly one-to-one talk because seniors may not be available. They have only one panacea. Madam, death on table consent liya hai. I mean, nothing else. So it includes everything, blanket, death on table. I mean, everybody must have faced this scenario.
Cannot be considered as a valid consent, right? Blanket consent cannot be considered as a valid consent.
Remote complications need not be bring to the notice. Remote complications need not be.
Shall we go to the question in chat box?
Madam, Dr. Avinash, can I say two things regarding the questions?
Yes, sir.
Yes,
Please
yes,
go
sir.
on.
Yes, sir, please.
One, there is no awareness case so far filed in India, means there is no awareness in the public that they can file awareness. They can, that is, there is no awareness. One. Number two, this death on table, madam, the Supreme Court has given, please, that Samira Kohli case, everyone should read. As Dr. Shivakumar sir mentioned, see the remote risk, he has mentioned remote risk, need not mentioned. Whenever I talk in the medical legal session, I will go to the court rulings. It is not my individual opinion. The court has mentioned clearly, Supreme Court, while taking the informed consent, all the remote risks need not be explained to the patient.
मेंदूला जर सूज आली तर थोडासा प्रॉब्लेम येऊ शकतो. तसं काही नाही झालं तर सगळं चांगलं होईल. आताचा रिपोर्ट पहिला रिपोर्ट चांगला.
Harankar sir, yes.
Sir, here you said that Remote complications need not
All,
be
madam, the court clearly mentioned it is defending his own judgment. You need not tell even the remotest complications whereby the patient refuses the treatment and he will go to the quackery. It mentions.
Yes.
So
Yes,
you
yes.
don't say, if you say, if I give anesthesia, you may die on table, then he will not accept anesthesia. Court defense. Court is very clear, madam. Please, if you read all the judgments, it is very clearly mentioned. Then there are two. One, first informed consent, that is Australia only, even that 0.01% consent is
Has
there.
to be mentioned.
It should be mentioned. But everywhere it is not like that. Remote chances need not be. Then that is the reason we say, during this, if any complication occurs, that is a general terminology. Any complication occurs, this will not be responsible. And even I will tell you, even if you get a consent for death on table, the patient
can get a litigation.
That is due to your negligence only. Thank you.
What is
Sir,
what is your opinion about? Yes.
I would like to ask Meenakshi Sundaram here. Sir, is there any litigation or any claim for or any medical legal case for post-operative visual loss?
Post-operative, yes, it is there in Shankar Nedra, this one, Chennai. In Chennai, there is a case, post-operative visual loss, only one case. Only one case. Even, madam, even that premature baby developed retinopathy, there is a case. So there is a case. I will send you the judgment. 2 cases.
And some ridiculous amounts.
Ask for the consent of post-operative visual loss in spine surgery.
Again, madam, that is the reason I am saying, see, if it is up to you and your patient, because the court says, even that remotest chances, if you explain that the patient may not accept the treatment, that is the only thing. But if you are afraid, you please tell, this is up to you. This is up to what I am saying. If suppose you are not taking a consent, my point is different. If suppose you have not taken a consent, then you have to defend. Then you defend, I have not explained to the patient, thinking that he may go for some other case as per the Supreme Court direction. That's what exactly I want to talk now.
Yes.
There is a one way you will be penalized. I am here to say there are so many court judgments. You quote that it depends upon your lawyer who is opposing you. If suppose he is not aware of the rules and regulations, then luckily we will win the case. That is how people are winning and losing the case. And I am happy that all the cases I have closed practicing. All the cases I have closed.
Sir, what is the legal value of audio and video consent?
Yeah, that is better. See, if suppose you are not, the person is not trustworthy, you can have, even we have taken a consent in the presence of an advocate. We asked him to bring one advocate. See, this and all, so that if any problem, that is a local rowdy, so we have done all the things. These are all varies from person to person. This video, audio recording and all, why it is necessary? He is signing it. He is signing it. Again, in the informed consent, I want to tell one thing. Always get a signature from the patient if he is aged more than 18 years. Always. It is not simply saying, I give my consent for my wife's surgery. It is not like that. He may be a witness, but always it should be for the patient. And anesthetists also should sign. These are all the areas which is saying. Informed consent means the two parties should sign.
That I think we should take all the consent in front of the camera.
Not necessary, sir.
See, even that is a two-edged weapon, huh? Because unless you are very sure about what you are going to say or the answers that you're going to give, don't use the video.
In that case, I want to say one thing. I was defending a case in Kerala. See, worst thing, they have the anesthetist was not there. He has gone for a cup of coffee. Junior was there, defend postgraduate, the patient expired, private hospital. But that hospital is having a CCTV facility inside the theater. It should not be there. Inside the theater. And that nursing home has supplied that CCTV footage to the police, stating that the anesthetist was not there.
Oh my God.
Say, this is that they are installing a CCTV inside the theater. This and all we are not supposed to accept. We have won that case also, but won that case in the sense we argued that that person is the respondent superior. See, even in Kerala, some of the hospitals are not giving signing the contract with the doctor. They treat them as freelancing anesthesiologist, but they pay monthly salary, so that they will not be held responsible for that as an employer. So by seeing why I am saying I will be ready to prepare a counterfeit of it, that is an experience, real experience. Even after 13 years, a case was filed against an anesthesiologist. 13 years. And the limitation rule, they say we are aware of the thing only a year back, so we are filing. Or else, as per limitation, after 2 years, you cannot file in the consumer. That was filed a criminal case also. That is a criminal.
But they can file a delay condonation file and this thing, and
sir, that condonation and all, the court just like that it accepts, sir. That is
yes.
Just like that it accepts. What is a condonation?
Yes.
12 years condonation. Just like that they accept. Varies from judge to judge. Varies from judge to judge.
They will be happy to accept it. Judges.
So when we say return and informed consent. So should it be actually written or printed material can be used?
Written. No printed, written. Even written is very difficult to substantiate, because all the patients argue, sir, while we are entering in the hospital in an emergency, they have asked us to write, sir, we have written, we have signed. So that the consent means it is also your defense tool. It doesn't mean that you are blanket, you are exempted from the draconian consumer law. Without a consent, 100% you will be caught. Even I will tell you, a thyroidectomy case expired in Chennai, consent not taken. But the surgeon said, I asked my staff nurse to get a consent. She has failed to take the consent.
Oh, my question is, what about the consent? It should be written.
In that case, they won the case.
That means all matters should be written by the patient and his relatives, or he can sign the printed consent form.
Sir, pre-printed forms, because informed consent means it has to be procedure specific. It has to be procedure specific. So it cannot be in a printed format. Previously, the consent we were taking, I am ready to undergo surgery under anesthesia. This is a blanket consent, whatever may be the surgery. Now it is not like that. So I will tell practically what I am thinking. You can try in your setup. What I am thinking, we can write small chapters regarding the common illnesses. Like I want to start with the PAH. I am thinking for the past 6 years not doing that. If you write about PAH and the anesthesia complications in the form of a booklet, it is easy to read for them. You can even write death on table can occur because they are reading. And if you find it very difficult to record all your complications, we can get a consent. I have read this book. You can even place the screenshot of that book. I have understood all the complications. I don't know whether it will work it or not, but instead of writing some 6 pages or 7 pages, it may help. You can think it like that, but always it should be in a written format, handwritten, no printed.
So the most common thing that they say that
where the consent was not taken, they won the case.
He won the case because I tell that. See,
because they won the case telling that the patient was well educated, having known the previously was admitted, and the relatives they brought him to the OT table. But there was having known this, the defendant the case, they won the case also.
Good. That's what I wanted to tell. That judge is a good judge. He said, without a consent, how they will accompany the patient to the theater. So that means there is no written consent, but oral consent is there, so the case dismissed. So the SAR is also aware. See, that is the reason I am saying, if you know about these cases, when you have failed to get a consent sometimes, oversight, you can use this case. No doubt there is a oral consent. They have come. These are all. I am not saying that you should not take consent. If suppose they say without taking a consent, he has won the case. With the consent, so many people have lost the case.
Yes. So they have accepted that implied consent.
No, oral consent. They are,
No, here,
Ah.
when the judge said that how can the patient be taken to the OT, it is like the implied
Implied,
consent.
yeah.
When-
It is just like, correct, madam. Correct. It is just like implied.
Yes, implied.
Correct.
Sir,
Avinash, just
yes,
a small comment. What we need to do is, circumstantially courts do agree. One similar case in Kerala, State Commission was there long back, 20 years back, where thyroidectomy was done, but patient died of stroke. And lawyer, they put up a case, and lawyer started from consent only. Everything was in place, but lawyers have a habit of, making you put to the job, proving everything. Actually, other party has to prove, but we are in the circuit. So what has happened was ki circumstantial evidences of patient coming for consultation, pre-op evaluation, then these steps were followed, and that automatically led that this consent must have been taken, and court accepted that. So geographic, these circumstantial evidences are also important besides what is implied, what is written, what is recorded audio, this thing. We have to defend it appropriately, and some intelligent lawyer people like Meenakshi Sundaram will be there to defend such cases.
We will defend. I am defending 4 cases now in Kerala. 4 cases in Kerala, very difficult also. Because
it seems that you have nexus with Kerala judges, like.
they are exchanging the information by mail. They are exchanging the information, but why I find it very difficult in that particular point is the medical board has given contra opinion against the anesthesiologist. That is the reason why we are struggling hard. See, when the board itself certifies anesthetist is at fault, what we can do? Just like this CCTV footage, everything. Difficult, but even then, as he is an anesthesiologist, we want to fight. We will defend.
No, but we need better defenses. The lawyers and doctors who are learning law, they should put their efforts together to defend. I see so many cases. Had they been defended appropriately, it would have really won by the.
Then I think even in Maharashtra, Dr. Bande is there, Dr. Pratibha Khani madam is there, Dr. Surekha Shinde madam is there. So easily you can form a legal team. You can.
It's already there.
Yes.
Oh, fine.
I see legal team is there.
Fine.
Madam Khani leads the team. Yeah.
Yes.
Then we will forward the email to Khani madam.
So I will set aside to you. I'll give you a call. No emails to you.
Set aside.
Sir, if many anesthesiologists are doing laparoscopic surgeries under regional anesthesia, if anything goes wrong, what will be the legal? Unmute all.
We're having some disturbance, I think.
Yes.
Avinash can put that audio off if possible.
Yes.
Yeah, Dr. Avinash, I answered this question. I rushed through the thing. Again, the court ruling. If there are 2 schools of thought, if you follow one, it is not considered as negligence.
Yes, I agree with you. Yeah.
Sir, Meenakshi Sundaram, sir, one question about the off-label use of the drugs. Many times, what is the legal aspect about this? Means legality. Off-label use of the drugs.
I don't know.
We are using many adjuvants for spinal anesthesia.
Yes.
So in that case, if there is some legal case, so
Madam,
where do we stand?
No, madam. Off-label means I could not understand. If you are writing it as bupivacaine with lignocaine, bupivacaine with clonidine, whether you are writing it or not, if you are not writing it, there is no discussion. If there is no record, no difference. That's all over.
No, see,
sir, for example, sir, dexmedetomidine is very rampantly used intrathecally. There are various, publications available, but that drug intrathecally is still not FDA approved. Maybe Madam wants to ask about that.
In that case, I will explain. If suppose inadvertently, see, when it is not ethically approved, why you are using that? If suppose inadvertently you have used, you can bring
not inadvertently, sir.
Intentionally, if you are using it intentionally, then you should know how to defend. With intentionally, when you are using, it should be approved.
What I have read about it, sir, because many a time we do not get ethical committee permission for these thesis purpose.
Yes,
so I have gone through it, and what I learned that in India, actually by DGCI, they have not permitted off-label use of the drugs.
Madam, again, let me be very clear. If you want to say off-label means you want to use drugs which are not approved by any committee. That's what
for
you
that purpose, like for intrathecal purpose.
Madam, if it is not approved, yes, if it is not approved, you should not use it. Definitely. If it is not approved, you should not use it. And that is the reason I used that statement. If it is inadvertently used and if it is recorded, then you can bring an expert witness in favor of you, stating that it can be used at times. But when you are bringing that expert witness, don't call Surekha Shinde, madam, who is authoritatively saying it is not approved for intrathecal usage. That is the thing I want to say. When it is not approved, it should not be used.
But then you are preventing by preventing the benefit, or you are not offering the benefit of that particular drug.
Madam, there are so many ways of giving benefit to the patient, not by a drug which is not approved. Because when it is not approved, how legally we can protect that? How we
cannot defend
working within a system?
But it is said that in pediatric patients, almost 90% drugs are being used as an off-label.
It should not be, madam. For court, it is not taken that because the court in Samira Kohli case, it has clearly mentioned, even with the good intent, you are not supposed to do that. Even with the good intent, because most of the time it happens in obstetrics, we would have seen in so many repeat cesarean sections, without informing the patient, they will do sterilization. Because in 10 years back, I have seen routinely, because they will say, this patient will come for third cesarean section, what we will do. Then they will put a fimbrial knot without writing it. Every time I used to say, why you are doing something good for the patient by spoiling your mind and health? They were doing, it should not be with a good intent. Madam, again, I stress, for doing something good to the patient, we should
Don't put yourself in trouble.
We should go through good way only.
We should not be
in a very broad sense, we should be selfish in a good sense. Think of yourself first and then the patient.
We have to be, madam, who will protect us? Who will protect us in case if you are getting cut?
But then you find so much.
Almost every one of us is using.
You find even the published research also on those drugs. They are not approved. Then what should be the standard?
No, Manisha.
But
Manisha.
Yes, madam.
Even if it is, there are publications, the drug which we are using, when it is, when the company is producing it, the company has to certify that it is for intrathecal use. Otherwise, there is no legal protection.
But madam, when there are a lot of publications which are coming up in international journals, and then when we are giving to our students some sort
no,
of
there
those,
are publications, but the drug which we are using, the drug we are using, which is available
that
in
means
India.
This FDA is not giving permission to them also.
Sir, here I would like to confess in front of this August gathering. My own publication is also there for intrathecal vaccine few years ago. By the time we realized it's not FDA, the dissertation was already done. So,
no, but because now our ethical committee is very, very stringent.
It is very stringent, and they think everything in a very. I mean, I was quite. I got through. I mean, I was lucky, but this. I mean, now I regret.
Because there is so long they have taken. No, it is getting.
Regret to be naive at that time.
Correct, madam. For that matter, dexmedetomidine is only approved for the ICUs for sedation and
yes,
not even so for so many indications. We are using it for so many other indications.
But madam, that is for IV use. IV we can justify because that route is approved.
That's okay. That's okay. But then the question remains. And so many other drugs are also being used as intrathecally. That is off-label use.
Opioids are also used. No?
Faculty, I will not give this message to any of you that to use it. No, not at all. I mean, I was.
Opioids are approved.
Wrongdoing.
Opioids are approved.
Opioids are approved.
Okay. Yes.
Opioids are approved, no doubt.
Yes, opioids are approved.
Opioids are approved, and but nothing else.
Even I think magnesium sulfate is also approved, I think.
No, I mean, I haven't found that, but okay. And there is one question in the chat box.
More than 90% drugs used in pediatric patients are off-label use, because manufacturer many a time there are some restraints about indications in pediatrics, lactating mother, obstetric patients. These are the cases where drugs are not many a time approved initially, at least.
See, Anjali, if the anesthesiologist is using it, it is according to his own responsibility. But officially, legally, there is no protection.
Yes, I do understand, madam, because as I said, DCGI has clearly not approved it.
Sir, propofol was not being used in pediatric patients few years ago. Now every pediatric anesthetist is using propofol as a
Hello. Hello, everybody. Hello.
Avinash, we will go on to the questions in the chat box. So
Yes, yes, we should respect the questions
the audience
also.
will get.
So audience,
will
yes.
get the answers.
So please, please, if anybody want to ask any question, please unmute yourself and please ask the question.
Hello, sir. Can I ask one question?
Yes, yes, please.
Sir, this is regarding consent for blood transfusion, sir. Madam has said that we are supposed to inform the patient and or his relatives about the possibilities of infection like HIV, HPSAG. So, supposing while informing all the possibilities and patient or the relatives refuse, so what should we do? And the patient is in need of, there is possibility of blood transfusion needed intraoperatively, and the consent, after explaining the consent, patient refuses, then what should we do?
Like what Dr. Meenakshi Sundaram said, that it's best written down, okay? Like a non, personal message. So these consents and all these things, it should be like, what we call in small letters, but mentioned. So if you know that there is a need for multiple transfusions, a very major surgery, better to take a consent. But what we have done is we've actually printed a separate consent form for blood transfusion. And that it's enumerated everything. Okay. So most of the times these consents, which are so well written, are not read. I mean, I will be very honest that even in front of me, if I want to read all the thing, it doesn't get read, but it has been mentioned. And when that person puts down his signature, he is supposed to be responsible for reading it. So if you mention everything, like Dr. Sundaram said, if you start mentioning everything, they will refuse the treatment. So you just have to take that into account and say that, this is our standard consent for blood transfusion. So it becomes non-personal and we are supposed to mention everything. That is how I see.
So, but madam, in this way, we are not informing the patient, but taking the consent. So that is valid?
They are supposed to, when you give them the page to sign, they are supposed to read.
But we are supposed to explain them or just ask them to take the signature from them? Is it okay?
See, no, listen to me, okay? So I explain, suppose I want to really, do a good job with my consent. What I would do is explain the first two. And then I say the rest are very rare. They may not happen, but they are there. They are mentioned, but they are very rare. HIV, the patient himself could ask you, will I get an HIV infection? That time you have to be very honest and you have to say, we have an excellent blood bank and we have to rely on the blood bank. You cannot take all the onus on yourself.
Okay, thanks, madam. One more question.
Hello.
Can I ask one more?
Hello.
Yes.
Hello.
Hello, Avinash.
My question is that supposing intraoperatively surgeon wants to give the blood to the patient, but as an anesthesiologist, I feel that single transfusion is not needed and I don't want to give. But it is being told to me that yes, please give the blood. So in that case, like what should be my stand, or what I'm not taking consent before. So what should I do that time?
When you cross-match blood, it's better to take a consent for blood transfusion. If you want to go against the surgeon, you have to be very, very careful. Okay, Dr. Manisha, I think you need to come into this. See, contradicting a surgeon on principle, I don't know how it works practically. May not work.
No, single transfusion, not nowadays they are saying not.
I know that very well. But if a surgeon insists, I would just give it.
Madam, thanks a lot.
Madam, shall I say one thing?
Hello,
Madam,
Avinash.
Madam.
Hello. Avinash, I am having one question for you. Hello.
Yes, Dr. Patel. Patil sir, bola.
Continue, please continue.
Patil sir, bola.
My question is for Meenakshi Sundaram. As far as he was talking about cross therapy, this thing, whether it is can we give anesthesia to a person having BA, MS degree in obstetric gynec in Maharashtra? Because there are a lot many surgeons nowadays practicing BA, MS, which they complete after that MS gynec. So what about cross-pathy?
Madam, sir.
As of now, sorry, sir.
Well, sir, just because he mentioned this question is to Dr. Meenakshi Sundaram, I started answering, madam. I will be very much
in Maharashtra, I am talking in Maharashtra.
The thing is, in Maharashtra, I have seen it is very peculiar because after Ayurvedic bachelor degree, they are doing MS allopathy degree. But what I want to convey, MS allopathy degree is acceptable as far as we are concerned. We are not bothered about that primary degree, whether it is MBBS or BAMS. Your medical council has certified that person is eligible to practice.
Sir, that MS degree is not in allopathy.
That is not allopathic degree. That's Ayurvedic only.
So that is Ayurvedic degree.
Sir, I will tell. I don't know. If it is Ayurvedic degree, you can jolly well refuse. Let Ayurvedic anesthesia comes. Then that Ayurvedic anesthetist will give anesthesia for that particular person. We are not supposed to give.
What about we people? I am a MBBS and anesthesiologist.
No, what I am saying, sir. See, if suppose a qualified surgeon is not available, when the qualified surgeon is not there, we are not supposed to give anesthesia. That is the rule. Morally also it is right. Legally also it is right. First, morally it is right. So we are not supposed to assist them, because assist means it is abetting the crime. If you assist them, it is abetting the crime. When there is a case, the team will be sued. As we said, it is a team. The team will be sued. That is one. Number two, the previous question, whether it is single unit transfusion or a double unit transfusion, what I want to say, now we are discussing only the legal terminologies. We are not here to go into the details of medical intricacies. This is what exactly we have to avoid in court also. In the court, if two doctors contradict that a single unit is not allowed, a single unit is allowed, if you say like that, then court will always rule in favor of the complainant. We are not here to discuss that, whether the surgeon or anesthetist agrees or not. It is not here. We are talking about legal parlance only. If suppose the patient dies without a transfusion of blood, both surgeon and anesthetist is responsible. If you have not taken prior consent before transfusing blood, you have to take a consent. If the patient is unconscious, you are in soup. Then you have to get a consent only from the attendants. That is not legally valid. So again, even if you get a consent that HIV transmission is possible by transfusion of blood, if HIV infection occurs, you are liable. Yes. Because just by getting a blanket consent, it can happen. You cannot excuse, you cannot escape. It is just you are sensitizing. You just tell so that some patients, already the doctor has informed us, then why should we file a complaint? In that way, he'll go. But if we catch hold of a good lawyer, that is not an excuse. By transfusing blood, a person will not get HIV. No.
Yes, Dr. Satyan Mantri. Dr. Satyan, you raise your hand. Please ask. Unmute
Thank you
yourself.
very much, Avinash sir. It's been a
Okay.
very nice hear me, and I must thank both the speakers for collaborative talk. One thing, I am very happy to see Anjali Savargawkar madam after so long. She has been my PG teacher in GMC Nagpur. One thing I wanted to mention that all the anesthesiologists across all the cities must be persuaded to take professional indemnity insurance, because there is a lot of reluctance in anesthesiologists. So that should always be made clear to all the anesthesiologists working under various IS platforms. It should be made clear, guidelines should be given that you should have professional indemnity coverage.
मी तेच सांगू नाही हात केलं ते बघितले सहसा त्यातले उत्तर झालेत बऱ्यापैकी.
Okay, there's one question which says, is anesthetist responsible for PCP and DT Act? If we are using the ultrasound, it's better to get yourself registered with the PCP and DT authorities.
I think we will deal with the questions in the chat box.
Chat box. We'll continue with the questions in the chat box.
Is clonidine approved for intrathecal use? I think it is approved for intrathecal use.
Yes, it is.
This is.
It is approved. There is one important question. In private practice, mostly we make PSC on table and write notes immediately pre-op. So will it be valid in court if you write PSC immediately?
Yes. Yes.
Question is to whom? Question is to whom, madam?
It is for anybody can answer, sir.
No, then it will be anyone.
Anybody answer, sir?
Anybody can.
Then the court says in all elective cases, a pre-operative inspection should have been done 24 hours prior to the scheduled procedure. Court says. In emergency, it is an emergency. So in emergency, they can see on the spot, because it is an emergency they are calling. All elective procedures, it should have been done 24 hours. Why we should know? You have to take the clue. I should not make an open comment. You have to see the patient as per the case sheet 24 hours earlier. So it is up to you to receive the message.
Sir, everybody got the message.
Write the date. Yeah, everybody got the message.
Thank
So
you.
Write the date before.
Oh, no, madam, no, sorry. Don't say like that. Right. It's a record.
You have to write the. You have
it is
to
recorded.
write the before the surgery.
Madam, that means you are not legally concerned. It is recorded. So we have to be very careful. It will be available on record permanently. So it should not be any statement.
So ideally should go for pre-operative assessment 24 hours.
Yes.
Yes.
So now with telemedicine getting the approvals, we can do video calls and just take down at least some thing if you cannot meet the patient. Yes. But some attempt must be made to at least get history and some previous.
Will it be accepted, madam? Will it be accepted in the?
Yes. Abroad, they're doing everything. Nobody sees the patient. They are all taking it on video, on telephonic conversation. Now they must be doing it on video.
Madam, abroad the system is different. There are nurse anesthetists who are doing pre-operative.
It is better to get a history with on the telephone than not having any history. I'm just telling you, we are all seeing our patient 24 hours before, but logistics is not all that favorable to everybody. And nowadays, we are only promoting daycare surgeries. We are promoting all these things, which are very harmful to the anesthetists. If you really see.
Madam, daycare surgery means you could have seen the patient a few days earlier.
2 days before, yes.
See, daycare means he's admitting, but see, this telemedicine and all, madam, you are saying whether it is approved in India or not, that is a different question. Are we that busy to examine the patient through telemedicine? Are we that
Sir,
busy?
with COVID now, it is accepted.
No, that's right. But are we that much busy? I don't know. Madam may be busy, but we are free to see the patient physically.
No, no, it's the surgeons. So the surgeons don't know they are operating till midnight. So patient has not paid money till midnight. They don't get posted. We have, sir, we have different problems from you. I can tell you that.
Yes.
That is beyond a legal discussion.
Yes,
Right.
madam.
Go to next.
Khani
Shall
madam,
we
what
go
you
to
said is
next
very
question?
correct.
There is a one Dr. Mohan Patak is waiting for questions since long time. Dr. Mohan Patak, please unmute yourself and ask question. Dr. Mohan Patak, are you there, Dr. Mohan Patak? Okay, there is no response from Dr. Patak.
Charging.
Question.
Dr.
Dr. Azam's question. Yeah, the question is for Khani madam. Madam, what about difficult spinal and giving multiple pricks and patient lands with paraplegia?
Yeah. So what is the question?
Question is the spinal is difficult and patient gets multiple pricks and lands with paraplegia. So I mean this only this much he has asked Dr. Azam. So what will be the stance of the
legal implication will be that have you treated the complication properly?
Okay, patient had paraplegia, but has it been treated in time?
Means many times paraplegia goes unnoticed. Please, everybody on this forum must understand that our post-op record that our spinal has worn off is very rarely there. Very, very rarely. We don't really, we just assume that spinal has worn off. But sometimes if it goes beyond 4 hours, it should really worry us and we should start investigating, or 3 hours, 4 hours, whatever. But we very rarely actually say that anesthesia is, patient has lifted legs or whatever. But we don't really record when the anesthesia, like for GA, we record that, okay, patient is talking, this, that. For regional, we don't. Even for blocks, we don't.
Should our Aldrich score include this? It includes actually Aldrich score.
No, it doesn't. It doesn't. It doesn't.
It says
that is for GA. It's for GA.
For GA. Okay.
It's for GA.
What investigations are must for anesthesia? There is various guidelines for pre-op investigations, and sometimes we don't do ECG, and if there is a cardiac arrest, then what will be the legal implication? In minor case, and they say don't do ECG or some other investigations.
I think guidelines will help in such situations.
Yes, we just stick to the update yourself with the guidelines and use them as your crutch.
Just 2 months ago only we have
yes
the Indian guidelines.
Yes, and just stick to the Indian guidelines. I think that will hold in court.
Okay.
So that means you need not do an X-ray or ECG to a patient who is not having any symptoms related to that system.
And depends upon the surgery, whether it's a surgery or in-depth surgery.
Yes, yes.
It's very well documented.
Yeah.
His patient
Actually, I don't know about the Indian guidelines, but Miller very clearly says that ECG is not required in asymptomatic patients.
Even patient
no, but we've got our own guidelines, so we should stick to that.
Yeah.
If patient is hypertensive, is it required?
Definitely. Then, yes. According to guidelines, yes.
It is better to be done.
It is case to case, sir. I mean, we are wise enough to know my case is undergoing what surgery. I mean, in good clinical practice, we justify ourselves actually. Even though it's a
new guidelines about 50 or like
when
that,
we say
they have
anesthesia is always major.
No,
How
See, basically, what I understand from the guidelines, our Indian guidelines, is that they are mainly for ASA 1 and 2 patients. If the ASA 1 and 2 patients is not having any complaints, then you don't need to do any investigation. But they don't say anything about ASA 3 and 4 patients, wherein you are supposed to do all the investigations that are advised.
That case, the Pratibha Khani madam, in their presentation, one case is madam shown that ECG was not done. His patient is hypertensive.
So they said that you can't really, but now we have Indian guidelines, we should just stick to those. Because you can't do investigations for everybody. And you just take the help of the Indian guidelines.
It is not a legal document.
Wherever possible, investigate more than less. If you find that the patients are very inquisitive, patients are asking too many questions, investigate more.
Yeah, actually guidelines are there for documentation, and if there is some medical legal issue.
Legal documents.
Documentation. And some medical issue arises out of that case. Suppose if it is not done and if there is a medical legal claim, then you can take use of those guidelines.
You can say that it is not necessary. Yes.
That's all is the purpose. Otherwise, you need to individualize every patient.
It's a tailor-made approach about what I think, you know.
I think
you can never be right. You can never be clinically correct everywhere. And like Dr. Sundaram says, you have to be ready with your defense.
I think this topic is never-ending topic, and we should stop somewhere in
we have
between.
To continue again. We have to continue again on 9th of August.
Yes.
Medical legal aspects and interactive session. So we will
Today we
continue on
will
9th of
stop
August.
here. I think
We'll continue
with
the
permission of
discussion on 9th
all of you, should we stop?
Yeah, just take this question. Is anesthetist responsible for PCPNDT Act? I hope everybody's got the message that we are using the ultrasound, so everybody needs to be registered with the local PCPNDT authority.
Yes. Yes.
Yes.
Okay, we can close now.
Yes.
Just Avinash,
Yes.
just one comment.
Yes, sir.
Now regarding ECG and all that, I just warning because there are a lot of discussion on Khani anesthesia group in between, and I showed so many ECGs of TVD patients who came for some non-operative as well as operative purposes, where ECG were full normal. In due course of time, they were found to be having triple vessel disease. So why I'm saying this, because ECG can be done as a requirement, whether it's legal or clinical, that is immaterial. But normal ECG and normal echo cannot rule out a very serious disease. And effort tolerance testing is more important or more clinically effective tool than these normal things done at rest. So just one parallel comment.
Yes, sir. Very good input, sir. Thank
Yes,
you.
yes, very
Thank
good.
you. Yes, sir. Thank you, sir.
Again, Dr. Avinash, I want to give a closing remark. Please avoid this sort of arguments, intricate arguments. ECG normal means even then there will be a problem. Then we will be getting caught. While we are preparing defense, we will say even if the patient dies because of cardiac anomaly, we will say we have taken a ECG. ECG was
and
normal.
ECG is normal. Yes.
So please, at that time, please, heaven's sake, medical conference is entirely different from a legal conference. So please don't talk about any intricacies in court. That lawyer Bande knows very well, but now he has acted as a MD general medicine, MD anesthesia.
Meenakshi Sundaram, this was caution, and there is a rising number of patients of this kind. I'm just worried that every 10th person will get confronted with this, and there will be a perioperative cardiac failure with ECG and echo normal. That is my worry.
I think we will continue the discussion on 9th of August, and I request all the chairpersons and moderators to join for the session. We will send you the flyer and the link also, because there is one more interesting session on medical legal implications, especially an interactive session. Avoid it.
Yes, it was an excellent presentation by our today's speaker, Dr. Meenakshi Sundaram sir and Pratibha Khani madam. I thank both of them. There was a very good expert comments and inputs by Dr. Anjali Savargaonkar madam and Surekha Shinde madam, who was today's chairperson. I thank them, and I thank also all the today's participated members of ISA in this today's session. Thank you very much. We'll meet soon in next month. Thank you. Good night.
Thank you very much. Thank you,
Dr.
Manisha.
Pratibha. Okay, yeah.
Thank you. Bye-bye.
Thank you, sir.
Bye-bye.
Thank you.
Varsha, please stop the recording.
We are meeting on 31st for the musical evening. Shravan. Just to remind everyone, on 31st, we are meeting for the musical evening of Shravan service.
Okay. Thank you.
Thank you.
Okay, thank you very much. Once again, I will end the meeting.